risk of overdiagnosis is an evident one with the rising incidence, especially of very early melanomas, so melanoma in situ and stage 1A melanomas with a quite constant mortality. So this is a topic by itself, but we will speak about follow-up. Actually, we recommend, and almost all guidelines recommend, at least a biannual follow-up in the first 5 years in stage 1A melanoma. And then almost all dermatologic guidelines recommend annual follow-up visits of every patient who had melanoma. Now, as a matter of fact, an increasing number of patients is living with melanoma, and the majority of these patients have an excellent diagnosis, and the resources are not increasing, so dermatologists are not getting more. So we need to rethink a little bit risk strategies and risk assessment of those who really need a lifelong surveillance. And of course, we know specific risk factors like a high nevus count, multiple primary melanomas, or genetical situations that predispose for melanoma development. These are a category by itself. But actually, there were also today in the morning sessions very interesting discussions how to identify better patients who benefit from close surveillance. And there is a very nice study, I will present it in my talk on Saturday, a very nice study from colleagues from Florence. And they demonstrated that melanomas, thin melanomas that may tend to metastasize are usually large tumors with a large diameter, more than 3 colors, dermoscopically characterized by atypical vessels, blue-gray color, but lack of pigment network. And histologically, they very commonly show a high mitosis and regression. So we are going a little bit in the direction also to identify clinically easy accessible features to understand better maybe these tumors or patients with these tumors may benefit from a closer surveillance, whereas others can be discharged after 10 years.